So I'm Mark Brown. I'm a professor of renal medicine at St George Hospital and the University of New South Wales in Sydney, Australia. And we've had a long-standing interest in developing renal supportive care programs for our dialysis and our non-dialysis pathway patients over the last, well, certainly 10 years and probably a little bit longer than that. And we've been fortunate enough to implement that a little bit across the state of New South Wales where I live, and now we're fortunate to see a little bit of this starting to progress nationally as well. So that's who I am and what we do, and looking forward to chatting about that.
Okay, well, good. I appreciate it. So we will give them your clinical journal, the American Society of Nephrology article from 2015. What type of update could you provide on your renal supportive care program since then?
So the program's been going very well since then. We've now managed in our own unit well over 300 patients on a conservative non-dialysis pathway. I think you'll be interested to know only 2 of those patients have decided at the last minute to change pathways, which I think is a tribute to the staff we have here who engage the families and patients very early on in the program. We're about to introduce a cardio-renal conservative pathway clinic as well. We've been impressed with a number of patients that have both cardiac and renal problems, and that's hopefully going to get underway quite soon. One of our nephrologist here is actually dual trained now in both as a palliative care specialist and a nephrologist, and she's going to help us to bring that clinic to the fore. At a state level, we've now seen over 3,500 patients managed across 20 different dialysis units in the program that we've set up at a statewide level, and that's been since mid-2015 and 2016 rather. And about half of those, 53%, are on a conservative pathway, and the remainder are dialysis patients receiving supportive care. So all of that's really been taking off across locally and across the state.
So if I could, let me ask you a 2-part question to follow up. First, I'm interested in what are you doing for the dialysis patients in terms of supportive care. Then I'll ask you, what are the components for your medical management without dialysis?
So for the dialysis patients, they come to us through two pathways. Either the nephrologist realizes that the patient's quite symptomatic despite what we believe are the best dialysis that we can offer, and looking at all of the appropriate dialysis parameters. Or we now have a pathway where they come directly from our dialysis nurses, because they're often the ones that really identify who's unwell, who's symptomatic, who's struggling with the whole dialysis process. And we've now got a blanket referral. They can just refer direct to the Renal Supportive Care Clinic for these patients to get better symptom management. It's also a flag for us to actually, introduce advanced care plans for that group if they haven't already had one done. And the other thing we're doing is every 6 months we have the surprise question, but the whole touch calc formula we use just to try and predict who's at increased mortality risk over the next 12 months. And we use that as our flag for which patients should have an advanced care plan definitely in place. So that's become our trigger, and we review those data every month as to whether the plans have been implemented yet or not.
What cutoff do you use on that touch calculation to do the advanced care planning?
Yeah, so we actually look at 50%. So we take a pretty high level, because in fact so many of them meet criteria anyway because of age and peripheral vascular disease and so forth. So we actually take a pretty high cutoff. Okay.
And so are your nephrologists okay with the nurses without going to them first, okay with the referral to renal supportive care?
Yeah, very much so. This is not something that happens overnight, and this is something that our unit has developed over quite a long time. So what we did really is we introduced renal supportive care clinical case discussions, journal reviews, and so on into our weekly department clinical meeting many, many years ago. And so it's become very much the ethos within the department that this is, the third arm of end-stage kidney disease management, the dialysis, transplantation, and supportive care. And so that then has led the nephrologists to become quite comfortable with having the senior nurses make these referrals.
Okay.
It is of interest that our senior renal supportive care nurse, she now actually almost vets the referrals. She looks into them to make sure that they're bona fide and that someone's not being referred because they've got a bit of an itch and it's actually due to some dermatitis or something. So
sure.
She's really helping out a lot as well.
So I'm trying to envision what you're doing. So you have somebody who's referred, they really maybe are failing to thrive on dialysis. They have a 50% predicted 6-month mortality, and you then have a shared decision-making and advanced care planning discussion. Is that what happens?
Yeah, so the nephrologist is then informed by our data manager that this is the list of your patients who fall into this category. And, the nephrologist agrees to undertake an advanced care plan with the patient and their family. That's the process. Aligned with that, those patients are also referred to, we have a dedicated renal supportive care clinic twice a week, and they are referred to that dedicated clinic where they'll be seen by our palliative care specialist and by a nephrology advanced trainee and by our nursing, social work and dietitian staff. And that's where they'll get the kind of whole comprehensive review of their symptoms, their psychological status, their spiritual welfare and so forth. We use the IPOS-renal at that clinic for every single patient at every single visit to get a sense of their true symptom burden and act upon that.
Okay, so these are dialysis patients that would be asked to go to this additional clinic?
Correct, that's right.
So in the United States, we have difficulty getting dialysis patients who already feel like their life is too regimented to go somewhere else at another time. How do you get them to attend?
Yeah, so it's once you've got to get them to that first visit. That's the key. And if they get to that first visit because we're telling them that we believe we can make their life better, that's once we get them to that first visit, they're okay. They engage in the program because they soon realize they've got a team that's looking after them, who's actually, cares about their welfare, cares about their symptoms, and cares about, their whole life really, and the social support for them and the psycho-spiritual support for them is very important. Yeah.
Sure. So is this a 24-hour 7 phone service that's available to your patients?
No, it's only working hours.
Okay.
After hours, if it was a crisis, they'd have to come through our emergency department.
Okay.
Then
all right.
one of us, yeah.
So the way you have Frank Brennan hired through your Department of Nephrology, some of us in palliative care and nephrology in the United States have started to sort of joke that there should be a palliative care nephrologist part of every nephrology group, large group practice. You're sort of doing that? I mean, how many nephrologists do you have and how many palliative care physicians do you have?
In our department, we've got 5.8 full-time nephrologists. I think it's about 8 of us. And we've got Frank is a 0.7 full-time appointment within the department. And that's worked very well. But I think there is two things to say about that. One is, this is just a personal view, but my personal view is that palliative care needs to change its models of care, in the sense that they have a palliative care department, and traditionally that's been oncology and cancer care. but there's so many of the palliative care specialists who truly understand what their job should be, and that is with chronic disease. So I would love to see palliative care specialists embedding themselves in all different departments. Quite interestingly, one of the spin-offs in our own hospital has just been happening in the last month or two. A different palliative care specialist is now embedding herself in the hematology department because she's watched this model of renal supportive care and now looking at a hematology supportive care kind of setup. So there's that kind of aspect. But I think the other thing too, we will never have enough palliative care specialists in this country to cover all of these, issues. So it means that nephrologists have to get well trained in the basics of palliative care delivery. And then we, have palliative care available to us for the highly specialized areas. And I think that's what we've learned in our unit. A lot of us, through Frank's teaching and osmosis working with him has been to learn how to manage a lot of the basics ourselves so that by the time he's seeing a lot of patients in the clinic now, they will have already been started on their various treatments for, their restless leg syndrome or their itch or whatever it is that we're addressing. And then he's got to take it from there. Yeah.
Right. So it sounds like you would agree. In the United States, we've come to the conclusion that we'll never have enough palliative care specialists and that we need nephrologists and nephrology nurse practitioners and nephrology nurses to learn primary palliative care skills.
Yeah.
And so you would agree with that. And then the next step is, have you developed protocols? Because you say people are going to the Renal Supportive Care Clinic, but they're already started on something, let's say, for their uremic itch.
Yeah, sure. Yeah, so we've got protocols. Well, we've got medication guidelines in our department, and we're actually in the process as we speak of redoing our website to include exactly what you're saying there, different protocols for different symptoms. There's also the Canadian website, Sarah Davison's group has got an excellent which I'm sure you know, an excellent website for looking at these sorts of things. And our website lists the various dosing and things of medications that needs to be modified in chronic kidney disease.
Yeah,
for these. So we've got those protocols, but I think more to the point is we've just had a lot of teaching.
Patients, you described this other one where they start and they're doing reasonably well, but over a period of 5 to 10 years, they're clearly going downhill. We would call them failing to thrive on dialysis. They might be referred to your Renal Supportive Care Clinic. Your nurses might identify them. And then there might even be a discussion then of dialysis withdrawal. Would that be part of it?
That would definitely be part of it. We use that sort of a scenario and also sentinel hospital admission events as a real red flag for us that we need to start having that conversation. And so,
okay.
and basically what we do is we tell the patient and their family that it is okay to withdraw from dialysis and that we will support them in every possible way when they do that. The real fundamental thing is that they don't feel abandoned. That's
okay.
absolutely fundamental to dialysis patients.
Okay. Now let's talk about the, do you call it conservative kidney management or comprehensive? Because what do you call if a patient chooses not to start dialysis?
Conservative kidney management is becoming the more favoured term. Sarah Davison pointed out to me quite rightly that every patient should have comprehensive care no matter what pathway they're on. So that wasn't a great word to keep in. So conservative kidney management, yeah.
Okay. So let's assume that you have somebody who's a stage 3 chronic kidney disease patient whose kidney failure is progressing over time. What will be the flag? You said you were using the touch calculation for patients already on dialysis. How do you identify those with chronic kidney disease for your Renal Supportive Care Program?
So we use the Renal Physicians Association of the USA's guidelines. I think they still stand up quite well. So which the surprise question plus the other issues of nutrition and their frailty uh, um, uh, performance measures and so forth, and their comorbidities. So, you know, we look at all of that. The other additional one, which we mention in our patient education program, is anybody over the age of 80.
Okay.
Anyone. And so I think, you know, as you'll be aware, there's increasing evidence that just having reached 80 and starting on dialysis, your survival may not be actually any greater than not going on dialysis. So we do raise that. We raise the issue that that's based on, you know, small amount of studies so far, but it's something that we put out. So they're the two kind of groups of patients, the 75 or older with those other features of the USA physicians group, and then the 80-year-olds, no matter what. Yeah.
Right. I'm wondering, what advice would you give to nephrologists, nurse practitioners, social workers, administrators? Would you recommend the approach you've taken? Do you get positive patient and family feedback? What are some lessons you've learned? What could you share about now looking back at this 10-year program?
I think the first thing is to be patient. You know, we had a lot of opposition to this in the early days. You know, some of it fairly aggressive opposition, but we believed this was the right thing to do. And I think that's the fundamental thing to keep in mind, that we're all trying to do the right thing for our patients and their families. And if you keep that in mind all of the time, I think it helps at a personal level to keep going with this cause. At a more systems level, I think one of the first issues is education around education of our colleagues that dialysis does not fix everything for a patient, especially an elderly comorbid patient. More education around the survival. I guess the last thing I'll say is we have a unit meeting every month where we discuss patients with GFRs below 15 who are heading towards a dialysis program and what the intended plans are. Any of those patients that are over 75, those cases are now presented every month in our department, where we discuss them amongst each other as to whether they're truly suitable patients for a dialysis program, and have they been offered the alternative of supportive care. They'll address those.
Well, I appreciate this. Has been great. We should do this more often. This is a good way to bridge the gap between Australia and the United States.
Absolutely. I've enjoyed it.